On behalf of my co-authors at the University of Missouri, I present the modified MacIntosh technique for pediatric ACL reconstruction using knotless all-suture anchor fixation. Diagnostic arthroscopy is first performed to identify the torn ACL and confirm it is not amenable to a physeal-sparing ACL repair technique. Debridement of the femoral and tibial ACL remnant is performed. A 5 to 6 centimeter longitudinal incision is made at the lateral knee from Gerdy's tubercle tracking proximally over the lateral epicondyle. A separate 2 to 3 centimeter transverse incision is made 15 centimeters proximal to the lateral epicondyle. Blunt dissection is performed down to the IT band. Soft tissue is cleared with a COB anteriorly, posteriorly, and proximally to ensure the full width of the IT band can be visualized. Subcutaneous exposure of the IT band is connected between the two incisions. A 15-blade scalpel is used to create a small stab incision at the posterior 1/3 of the IT band at the approximate level of the joint line. Long MacIntosh scissors are used to extend the fascial rent proximally. Another stab incision is made 2 centimeters anteriorly, and the process is repeated. After confirming a length of 15 centimeters, the 2 centimeter strip of IT band is then transversely cut at the proximal incision to complete the proximal harvest. The 2 by 15 centimeter strip of IT band is delivered out of the wound distally and whip stitched. The 2 centimeter swath of IT band is released down to the level of Gerdy's tubercle for increased mobilization. Note the harvested IT band autograft is not released transversely from its insertion at Gerdy's tubercle. This insertion is necessary to anchor the harvested IT band strip for eventual extra-articular and intra-articular reconstruction. Also note the deep Kaplan's fibers are not released from the posterior IT band to preserve their function as rotational constraint. MacIntosh scissors and a Kelly clamp are used to dissect along the posterolateral femoral condyle through the intermuscular septum and into the notch intra-articularly. An arthroscope is used to visualize the clamp as it enters the notch. A fibrolink suture is then introduced into the knee through the anterior medial portal and brought to the clamp. The looped end of the fibrolink suture is delivered through the notch and around the posterolateral femoral condyle. The fibrolink is then used as a shuttle suture to deliver the whip-stitched IT band autograft into the joint. At this time, the free end of the whip-stitched IT band autograft is exiting the anterior medial portal. Attention is turned towards the extra-articular tenodesis of the IT band autograft into periosteum at the posterolateral femur to act as an extra-articular rotational constraint. The knee is placed in 30 degrees of flexion and tension is pulled on the whip-stitched IT band. A 1.3 millimeter fiber tape is used to pass a horizontal mattress stitch through the IT band, bracketed here in yellow, and periosteum at the approximate location of the intermuscular septum, bracketed here in green. This is reinforced with a figure of 8 suture for final extra-articular tenodesis. Next, a hemostat is used to bluntly dissect proximally into the joint and under the intermeniscal ligament through a 2 centimeter anteromedial incision at the proximal tibia. A shaver is used to clear the fat pad from around the hemostat, and a burr is used to create a small trough in the anterior tibial bone. This improves local biology via bleeding to promote long-term incorporation at the graft-bone interface. The free end of the IT band autograft is retrieved, shuttled beneath the fat pad, and beneath the intermeniscal ligament with a hemostat clamp. The periosteum over the anterior medial tibia is incised with a number 15 blade scalpel. Fluoroscopy is used to confirm an extraphyseal proximal metaphyseal location, and a double-loaded 2.6 millimeter fiber tack anchor is placed at the anterior medial proximal tibia. The IT band autograft is then fixed to the proximal tibia by use of the fiber tack anchor in suture staple configuration. This is performed with tension on the whip-stitched end of the IT band autograft and the knee in full extension or hyperextension to avoid overconstraint. The free end of the autograft is placed through both loops of the anchor, and the distal loop is converted through the anchor. After the distal loop is fully tensioned, the autograft is then delivered retrograde through the proximal loop. The proximal loop is converted through the anchor, and both loops are sequentially tensioned to confirm final fixation. The free ends of the suture are tied and cut. The knee is taken through gentle range of motion to confirm full flexion and extension. Appropriate intra-articular tension is confirmed arthroscopically. The tourniquet is let down and hemostasis is achieved with electrocautery, extra-articularly and intra-articularly, as postoperative hemarthrosis may disproportionately predispose pediatric patients towards limitations in range of motion and associated arthrofibrosis. Patients with no meniscal pathology are kept toe-touch weight-bearing and extension until quadriceps activity returns. They have no range of motion limitations. Patients with meniscal pathology are kept toe-touch weight-bearing and extension for 2 to 6 weeks depending on tear morphology. Active range of motion is limited from 0 to 30 degrees for weeks 0 to 2 and 0 to 90 degrees for weeks 2 to 6. Regardless, patients are kept from running and sports-related activities for 3 months. Seen here is postoperative incision healing and demonstration of a non-antalgic gait pattern at 3 months postoperatively. Thank you.